Hello and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Zachary Schwartz. This is episode 2 of our series on CMV and kidney transplant. We'll discuss designing CMV antiviral regimens for high-risk kidney transplant recipients, including strategies for prevention and characteristics of available antivirals. I'm joined by Dr. Marcus Pereira from Columbia University Irving Medical Center in New York. To see the full program, including the accompanying slides for this podcast and the other episodes, please visit the show notes. Now let's start things off with Dr. Pereira.
So what are those strategies? So there's two major categories, and then there's a new approach as well. So prophylaxis, what do we mean by prophylaxis? That's an antiviral drug that's given for a fixed period, depending on the organ and depending on the serological status of the donor and the recipient. So for example, for kidney transplant recipients at my center, a D plus R plus gets 3 months, whereas a D plus R minus gets 6 months of prophylaxis. And that's generally what's recommended in the guidelines. Now, the second approach is preemptive therapy, or the new term is surveillance with preemptive therapy. And that's where you don't give an antiviral drug right off the bat. You actually just monitor your patient with serial PCR monitoring, usually on a weekly basis. And if that becomes positive, if you achieve a certain threshold, many centers pick 1,000 IUs per ml, but that's really very center dependent. If you achieve that threshold, then you treat. You put your patient on antiviral therapy until that viral load is once again undetectable. You stop and resume monitoring. Now, there's a hybrid approach that a lot of centers pick the best of both approaches, which is you give them antiviral prophylaxis, and then after it ends, now you survey your patient with serial PCRs. A lot of centers actually do that. We do that as well. So how do you compare those two strategies? They certainly get debated over and over again. As you can imagine, with antiviral prophylaxis, it's highly effective, but there's a drug cost attached to it. Right now, you're prescribing either valganciclovir or letermovir, and there's always a cost to those drugs. There's drug toxicities related to those two medications, and we'll be talking about those as well. It turns out that if you actually prevent CMV from reactivating in the first several months after transplant, what you're doing, you're protecting your patient, but in some ways, you're also delaying the reactivation of CMV for later in their transplant lives, sort of this delayed onset post-prophylaxis. So your patient will always remain at risk, although diminished over time, there will always be a risk. And that's important for you to realize that there is this post-prophylaxis CMV reactivation. The other aspect that we talked about in terms of indirect effects of CMV, prophylaxis certainly is able to prevent some of those indirect effects. Now, what about surveillance with preemptive? It does involve weekly PCR monitoring, so there is certainly a logistical issue with that. Like your patient has to go to a lab once a week. Somebody has to follow those results and have the plan to enact if those results are positive. So there's a logistical sort of greater challenge with that preemptive approach. But it does allow for low-level CMV replication, which in some ways can be controlled. And in that setting, you're priming the immune system to perhaps acquire some degree of immunity to CMV that may have some benefits downstream. But again, the logistics can be quite complicated, and which is why a lot of centers, and particularly in the US, choose more prophylaxis than preemptive therapy. All right, so have there been any studies for kidney transplant recipients comparing the two approaches? This is one of the few studies that compare those two approaches. This was an open label, single center randomized control trial comparing with 140 kidney transplant recipients, comparing preemptive therapy with antiviral prophylaxis, which is in this case was valganciclovir, 900 milligrams PO daily for 3 months, obviously adjusted for renal insufficiency and other changes. And if they were D plus or minus, they would get 6 months as opposed to 3 months. So 47% of those patients received induction therapy. And just to say, if they had on the preemptive therapy arm, if CMV reactivated, then they would get full dose valganciclovir. So the incidence of acute rejection, which was one of the primary outcomes, turns out that it was actually lower in the prophylaxis arm. So again, I think that that's speaking of the indirect effects of CMV. If you're suppressing CMV from reactivating, there's less of that alloreactivity and maybe concerns for rejection down the line. And in this case, it was not necessarily statistically significant for the cohort as a whole. It was 23 versus 13%, but did not achieve statistical significance. But in the subgroup of those patients who did not receive induction therapy, that was actually statistically significant in terms of valganciclovir group for prophylaxis had lower rates of rejection compared to the preemptive group. So maybe some benefit in certain categories of patients. So what were some of the other outcomes from that study? So there was also subclinical rejection, right? We talked about biopsy proven, but there's also a whole other category, which is subclinical. And that was also lower in the prophylaxis group, and that was significant. So 13 versus 29%. CMV DNA, the anemia rates were higher in the preemptive therapy group. That shouldn't be any surprise, right? Like you allowed those patients to reactivate. But, and also not surprising, neutropenia rates were also higher in the prophylaxis group. They're getting valganciclovir. That's one of the main side effects and toxicities of valganciclovir, which is bone marrow suppression, neutropenia, and thrombocytopenia. In terms of subclinical rejection, valganciclovir did better than preemptive therapy. And there's a similar figure in terms of neutropenia the other way around. All right, valganciclovir is no longer the only therapy or antiviral available for prophylaxis. So we talked about valganciclovir is FDA approved for CMV prevention of kidney, heart, or lung patients who are at high risk, and that's been approved since 2003. It's been with us for a while, and there's a whole lot of experience with us using that medication, and it is still the most commonly used drug. And then there's letermovir. That was a new drug. It was approved for CMV prevention for our allogeneic stem cell transplant recipients in 2017. And based on some studies, it was approved or extended for high-risk kidney transplant recipients in 2023. Now, some of the positive aspects of letermovir are that they don't have the same side effect profile as valganciclovir. It's not associated with cytotoxicity, meaning you don't have any bone marrow suppression with letermovir, or any renal toxicity or renal adjustments. And those are important considerations. There are some reports of CMV treatment failures with letermovir, so letermovir cannot be used for treatment. Remember, we're talking about prophylaxis only. Now, other drugs that we don't use for prophylaxis but are available are foscarnet, cidofovir, and maribavir, and we'll not be talking about those additional drugs during this session. All right, so the study that I alluded to was this phase 3 randomized control trial in high-risk kidney transplant recipients comparing letermovir with valganciclovir for CMV prophylaxis. And this included 589 D plus R minus patients, and they were given prophylaxis for up to 200 days, so pretty standard duration. And in a nutshell, letermovir was found to be non-inferior with the primary outcome, which was preventing CMV disease through week 52. So here you see there was a 10.4 incidence of CMV disease incidence in the letermovir arm, and valganciclovir actually had a higher rate at 11.8. But certainly within the non-inferior analyses, these drugs were quite comparable in their efficacy. But what was really striking was actually the side effect profile, the treatment-related complications in that letermovir for all the categories that are pertinent, including bone marrow suppression, leukopenia, thrombocytopenia, and so forth. Letermovir did much better than valganciclovir. And again, that shouldn't be a surprise. This is not a drug that causes bone marrow suppression. Therefore, you shouldn't see that as a side effect. And thankfully, we did not. So that in some ways had an improved safety profile compared to valganciclovir. When you're choosing between valganciclovir and letermovir, what are some of the things for you to think about in your choices? So certainly antiviral toxicities. Again, valganciclovir has this bone marrow suppression issue. Certainly, I think you're going to see neutropenia, which is not a benign side effect, thrombocytopenia, as well as the need for renal adjustments, which certainly adds a complication to valganciclovir. Letermovir, on the other hand, has some GI side effects. So there are some nausea and diarrhea issues reported, and maybe some mild headache, but otherwise no systemic side effects. And then monitoring considerations. So renal function changes. Valganciclovir has a very narrow window when it comes to renal adjustment. So you really have to stay on top of your creatinine clearance and make sure that your team is adjusting the dosage of valganciclovir. And that adds its own layer of complexities, whereas letermovir does not. Drug interactions, important to know that letermovir does increase levels of tacrolimus and sirolimus, and that's important to know, so you do have to consider other issues. And then role of therapeutic monitoring. I get asked a lot about that. Can you check valganciclovir or ganciclovir levels? And in general, there is no way to interpret those levels, so we don't. The same for letermovir. We don't measure levels or are able to interpret that. And then what are some additional considerations? So certainly convenience and ease of administration. We've been talking about that. Both are orally administered. The frequency of doses is generally the same. Adjustments we talked about and drug interactions. And then last is the cost. There's a certain element of affordability that you want to keep in mind for your patients. Valganciclovir is now generic, whereas letermovir is not. So important. But there are certainly some downstream effects in terms of monitoring labs and adjusting your dose and keeping your team busy with keeping up with creatinine clearance and dose adjustments. So all of that is to say it's a complicated decision process. And I think you want to work on what's best for your patient. And some of these patients are quite unique.
Thank you to our faculty, and thanks to you, our listeners, for joining us. To learn more from our program on minimizing CMV and high-risk kidney transplant recipients, click the link in the show notes. And to get access to all of our new podcasts, you can subscribe to the CCO Infectious Disease podcast on your favorite podcast player. Thank you, and we'll see you on the next podcast soon.